Thank you for finding time to join us in this Bloodless Medicine and Surgery Week of the year 2021. We started the first virtual meeting last year. It was very successful. And I want to congratulate the organizers for putting it together again. I want to thank them also for giving me the opportunity to share my thoughts on the subject of blood salvage in emergencies at this very important meeting. I have no disclosures. I'm a Christian, I'm a Presbyterian. I just want to let us know that this presentation would be biased towards resource challenge settings. Next slide, please. I would like to go through a brief introduction, and I would like to talk about what blood salvage is. And I want to let us know what we do here in our part of the world. I also want to share with us what others do in other parts of the world. We'll do a brief overview of the literature on the subject, and we'll just talk a little bit about what I think we can do for improved outcomes. Then we'll conclude. Thank you very much. Next slide. The pillars of patient blood management are well known to all of us. And as we know, patient blood management is a multidisciplinary and individualized patient blood management focused with the aim of improving patient outcomes. And bloodless medicine and surgery, in addition to the three pillars of patient blood management, can I have the next slide, please? Also talks about optimizing oxygen delivery. The other pillars of patient blood management are to optimize the hematocrit, to minimize blood loss, and to lower the transfusion trigger. We also emphasize the need to optimize oxygen delivery. And that basically means looking at oxygen delivery and oxygen consumption and trying to tilt the balance in favor of oxygen delivery for improved patient outcomes. Next slide, please. So when we talk about medical and surgical emergencies, we are talking about an injury or illness that is acute and poses an immediate risk to a person's life or long-term health. And it's extremely important to attend to these patients immediately. Early identification of a medical emergency and subsequent management will be helpful to save the patient's life and also prevent irreversible consequences. Sudden injury or serious illness that, if not treated right away, could cause death or serious harm is another brief way of defining medical and surgical emergencies. Now, all of us who have managed an emergency room know that some of the common things that we will see will be sudden cardiac arrest, which are in our part of the world usually would be brought in dead. Then we have a myocardial infarction, we have anaphylactic shock, we have stroke, we have acute asthmatic attacks, hypoglycemic coma, and also other diabetic comas. We have convulsions, loss of consciousness or disorientation. We have high fever. We have a moderate to severe burns, poisoning, overdose of drugs, sudden loss of vision, numbness, weakness, confusion, slurred speech, homicidal or suicidal feelings. And then I have put in red the ones that usually cause bleeding. We can have a patient presenting with excessive or uncontrollable bleeding as a result of wound from gunshots or deep knife wounds. We can have pregnancy-related complications, including antepartum hemorrhage, postpartum hemorrhage, and ectopic pregnancies. We can have fractures, especially open fractures, and we can have trauma from different causes. And motorcycle accidents were common a few years back in our environment until motorcycles were banned in the urban areas, and we still have road traffic accidents causing a lot of trauma presenting in our accident and emergency departments. So the basic approach in an emergency is to manage the airway, breathing, circulation, disability, and then exposure. That approach does not change. Now, cell salvage is an autologous transfusion technique that collects blood from a patient's bleeding site. well, sometimes we say operation site when we are talking about surgery, and then processes it in a cell salvage machine. Sometimes it's not in a cell salvage machine, as we are going to see in the course of this discussion, and infuses it back to the patient. So historically, it all started in 1874 when Highmore in the United Kingdom proposed the idea of reinfusing shed blood during postpartum hemorrhage. William Halsted in 1883 reported a technique for reinfusion of blood, where he described the use of autologous blood for carbon monoxide poisoning. And then in 1886, Duncan used it for management of crushed injury of the lower limbs. While in 1914, the German gynecologist Theiss reported autotransfusion in 3 patients with ruptured ectopic pregnancies. In the 1940s and 1950s, with advancements in allogenic blood transfusion, much progress was not made in autotransfusion. But in 1968, Wilson and Taswell in Mayo Clinic designed the first prototype device with the capability of washing collected blood in a centrifuge bowl. While in 1969, a surgeon and researcher introduced a device with a cardiotomy reservoir and a roller pump that was marketed by Bentley, and it was called the Bentley Auto Transfuser. The term cell saver came up in 1974 when Haemonetics marketed the first commercial device to collect, wash, and concentrate autologous red cells for reinfusion. Recently, cell saver refers to blood salvage devices that are used mostly perioperatively. Now, there are indications for cell salvage. If we have surgery where anticipated intraoperative blood loss is going to be more than 1 liter or more than 20% of the blood volume, like we are talking about pediatric patients, we cannot expect to wait till the blood loss of 1 liter. If we have preoperative anemia in a patient or patients with increased risk factors for bleeding, if we have patients with rare blood groups or antibodies, if we have a patient who refuses to receive allogenic blood transfusion, and then again, the American Association of Blood Banks suggests cell salvage to be indicated in surgery where blood would ordinarily be cross-matched, or where more than 10% of the patients undergoing the procedure usually require transfusion. So what do we do in our part of the world? In our part of the world, you can see there a funnel with a gauze. And then you can see an operating site. And what we do is a scoop and a sieve technique. Next slide, please. So basically, it's mainly done in laparotomies. In my practice, I have seen a lot of it done during splenectomies and ectopic pregnancies, especially. A small midline subumbilical incision is made, and the peritoneum is incised and then tented to avoid spillage. Blood is carefully scooped using a sterile gallipot, and that blood is then passed through. There are different practices around the country. In preparation for this topic, I called around because I couldn't see a lot of literature. And so I called around to know what we do around the country. And anything from 2 to 6 layers of gauze is used. And then blood is filtered and collected in a receiving bowl with anticoagulants. Sometimes in some places, in remote locations, anticoagulant is not available and the blood is still used. So blood is put into a blood bag and reinfused into the patient using a blood giving set. Now we have a paper presented by Ojeme. He is originally a Nigerian, and he put together his thoughts and he tried to review the literature on our practice of cell salvage. And basically what I have described is what he found in the literature. And he came to the conclusion that autologous blood transfusion, even using our crude technique, was not inferior to homologous blood transfusion in this group of patients in terms of adverse effects. Next slide, please. So what do others do in other parts of the world? You can see there an array of different cell savers, ranging from the ones that use small centrifuge bowls to the ones that do continuous salvage, which can use very minute quantities of blood, and therefore they can be used in the pediatric age group. Next slide. So basically it involves suction. Blood is suctioned away from the operating site using a dual lumen tube, and then it is mixed immediately with anticoagulant to a custom-made reservoir. Next, the blood is filtered. So this filtration removes large clots and debris. Following that, the rest of the blood is put into a centrifuge. Of course, the whole process is automated, and sterile isotonic saline solution is pumped into the centrifuge bowl. This, the force of the pump holds the more dense red blood cells against the outer wall of the centrifuge bowl, while the plasma moves to the center and spills into a scavenging or waste bag. Now, you can see in the photograph there, the whole process as described, where the dual lumen tube takes the blood from the operation site, and then the initial filtration, then it gets into the cell saver, and you can see the waste bag, while the rest of the blood is returned to the patient. So the waste products usually include white blood cells, platelets, plasma, anticoagulant, fat, clotting factors, and free plasma hemoglobin. And they are collected, like I said, in a bag and disposed as clinical waste. In the last NATA conference, I'm sure Hemocare is going to present their novel equipment, which has the advantage of preserving the platelets. And of course, we know that that has implications for coagulation of the blood and preventing dilutional coagulopathy in this group of patients. So cell salvage blood is then collected in a separate bag and reinfusion back to the patient. If some say 4 hours, the average I've seen in the literature is about 6 hours, but not more than 8 hours after processing, provided it is kept at room temperature. If it has to be kept beyond that period, it has to be kept at a temperature of 1 to 6 degrees Celsius. And then again, it must be used within 24 hours. It must be properly labeled. And there are, in places where this is being, a lot of processes are being put in place, a well-written protocol guiding cell salvage blood should be written, and on no account should salvage blood be used on a patient different from the patient where it was salvaged from. If citrate is used, there's usually rapid liver metabolism that prevents citrate toxicity. But if you have a patient with impaired hepatic function, the citrate toxicity may occur, and that can be corrected using 10 mils of 10% calcium gluconate. Next, please. Now, basically, cell savers can process a full reservoir of blood in approximately 3 minutes. So that results in about 55 to 250 mils of red blood cells with hemoglobin concentration as high as 17 grams per DL. And this is very useful when we are dealing with life-threatening hemorrhaging emergencies. Now, for those people that we are worried about infection and all of that, we can now use, in addition to the processes that we had talked about earlier, we can use leukocyte depletion filter to improve the safety and decrease contamination. The advantage of cell salvage in emergencies is that it saves time. It saves the time of sourcing for donors. In our part of the world, sometimes there's an emergency and then, oh, this patient is bleeding, let's look for donors. And then we deal on a fee-for-service system. So many times the patients do not have money. And for all of us, how many people would have money in an emergency situation? So the money is not available. You look for the money, look for the donor, pay for cross-matching, and a lot of time is being wasted. So cell salvage in emergency saves this time. And of course, it also saves the time. Even if the blood is available in the blood bank, it also saves the movement from the theater to the blood bank, what I call the theater blood bank shuttle. So it does not have the risk of ABO incompatibility. And in the cases where we have rare blood groups or alloantibodies, it comes in handy. It is acceptable to patients for whom allogenic blood transfusion is not an option. It also reduces the demand for allogenic blood. That has been shown severally in published literature. It maintains a normal concentration of 2,3 DPG, and the removal of activated clotting factors and inflammatory cytokines. Cells can be reinfused, as I said earlier, at room temperature, and it reduces the risk of transmission of blood-borne infections. Every good thing, of course, has its own disadvantages. The downside is that there is an initial equipment cost, and then there is the cost of disposables. Then there's need to train the staff and to maintain competencies in the use of the device. And in some cases, it can be a complex device, but like everything else, there's a lot of, the last meeting of NATA that I attended, I saw a lot of efforts to simplify the device by many companies, which I believe will be presenting in this meeting. The risk of bacterial contamination can be reduced using leukodepletion filters. And this has been shown to reduce the risk of infection by as much as 98 to 100%. It can also cause electrolyte imbalance, so that needs to be watched out for. And there could be air and fat embolism. So I usually compare what we do, like I said earlier, and what is done in other parts of the world to the mortar and pestle versus the blender. In our part of the world, crayfish is a very useful ingredient for making most of our soups. And many of us grew up pounding crayfish using the mortar and pestle. And over the years, we got accustomed to the blender. It makes the process faster, it makes it easier, it makes it simpler. But basically, some people still prefer to blend their crayfish using the mortar and the pestle. Next slide, please. So our cell salvage machines, I believe, must be carefully selected. And in selecting it, I mean that it should be simple for our part of the world. Like I said, this presentation is biased towards our part of the world. I believe that what will be applicable in our part of the world should be simple, should be effective, should be locally produced as much as possible. Even if it starts out being produced elsewhere, there should be efforts to engage local engineers in doing something locally. And it should be electricity independent, because we have a lot of power outages and electricity challenges in our part of the world. It should be easy to repair. It should be durable and available, and should have the consumables should be available. This is the only way it can work in emergencies, where all of these things are a challenge, especially in remote locations. Next slide, please. So in the literature, we have autologous blood transfusion during emergency trauma surgery. And this research concluded that intraoperative cell salvage produces an effective and cost-efficient resuscitation as an alternative to allogenic blood transfusion in trauma patients undergoing emergency operative procedures. And there are several such literatures. Please, next slide. There are several such literatures, a lot of publications about what people are doing with cell salvage around the world, even in emergencies. This study was aimed at looking at vaginal blood loss, whether it could be suitable for reinfusion. The blood that was salvaged was not actually reinfused into the patient, but the study showed that blood that is salvaged from vaginal blood can actually be up to the quality that could be reinfused into the patient. So if we have a life-threatening postpartum hemorrhage, even in the labor ward, vaginal blood can actually be salvaged and used in this group of patients. Next slide, please. Please, can you move the slide for me? Okay, so we have a lot more literature. We have a case series of intraoperative blood salvage in 11 hemorrhagic trauma patients with enterically contaminated wounds. This study was aimed at, it's actually a report of cases that were done in trauma patients. And they found out that the blood could actually be retransfused into the patients, and it was life-saving in this case, and there was no significant death. Next slide, please. Okay, so blood salvage, if available, can be helpful in managing patients at risk of postpartum hemorrhage. Like we know, we contribute significantly to maternal mortality. And one of the causes of our high maternal mortality rate is postpartum hemorrhage. And if it is possible to salvage blood that is being lost at PPH, it will be a very good thing. And this study has demonstrated that if there could be preoperative planning for its use, it can be prudent in obstetric patients at high risk for significant PPH, like patients with placenta accreta. In some centers, blood salvage is used routinely for patients undergoing cesarean section and in patients who develop abnormal bleeding during the procedure. The advantage of using it routinely is that everybody becomes well versed with the process, so that if you now have a patient that has life-threatening postpartum hemorrhage, some of them are not pre-diagnosed. Most of the time, in all the cases that we have diagnosed placenta accreta in our environment that I have been involved with, it has been diagnosed on the operating table. And it's usually not a good scenario to find oneself. We have had abdominal pregnancies that that were not diagnosed preoperatively. Of course, that was several years ago, before ultrasound sonography became as developed and as well practiced as it is in our part of the world. But basically what I'm saying is that if cell salvage becomes routine in our environment, then sudden life-threatening postpartum hemorrhage will not catch us unawares. And then Sullivan and colleagues have demonstrated this using a case series of about 1,170 reinfused patients. Next slide, please. So much in the literature. So there was this other study about intraoperative cell salvage in the combat support hospital. And of course, in a military combat, that is one place where blood becomes very important, and it becomes sometimes a very scarce commodity, providing them even in the best places with the kind of environment that we are at home with in our part of the world. This study showed that salvage is most successful in patients with gunshot wounds and cavity injuries, and it is less appropriate for limb and blast injuries. However, the results of this study present more arguments against intraoperative blood salvage than for it. And the authors have requested for further research to determine the safety in combat settings. So evidence for the use of cell salvage in individuals undergoing abdominal and thoracic trauma surgery in another study was shown to remain equivocal. And they also advocated for large multi-center methodologically rigorous trials to assess the relative efficacy, safety, and cost effectiveness of cell salvage in different surgical procedures, especially in the emergency context. Now, what can we do in our environment for improved outcomes? One of the things I found out, I called around because I couldn't find literature, local literature on the availability of cell salvage in our part of the world, especially in our country. I called around all the hospitals, and not even one has a cell salvage machine, that is the cell saver. So what is commonly practiced in our environment, what everybody is well practiced with, is the scoop and save, technique. So we need to know what is available. We need to maximize the available resources, and we need to improvise where necessary. Even the scoop and save technique, you find out that depending on where people practice, they have been able to improvise based on what they have. And we should focus on the whole patient and every aspect of care. That means that while looking at the bleeding, we should look at other things. Is the patient hypothermic? Is the patient, having other things that could predispose to other morbidities or that could further the bleeding process? If the patient is hypothermic, we know that not only will the patient bleed, but the patient can get into dilutional coagulopathy state. So we have to look at all of these. We have to look at other aspects of the patient's management apart from just the bleeding. So we must focus on the whole patient when we are dealing with life-threatening bleeding scenarios, apart from the bleeding. Balancing the oxygen delivery with the oxygen consumption is absolutely important in these cases. So advocacy for new equipment, including cell savers. As we can see, there is a big market. Nigeria has 200 million people. So if everybody is doing the best they can in the situation that we are in, imagine if we have cell savers that meet our criteria, that can be selected, then we can be sure that we are in the best position to give the best care to our patients. We should not also forget point of care analyzers, because sometimes patients with life-threatening hemorrhages can also have electrolyte imbalances. And if we are not even able to diagnose them, then we are not able to manage them. How about the coagulopathies? Sometimes if we are not able to look at the thromboelastography or ROTEM as is well available in other places, managing these patients become very difficult. And this is the situation we often find ourselves here in our part of the world. These are some of the efforts that have been made. The EAT set was produced by General Ovaje, a Nigerian anesthetist. And he tried to automate the scoop and sieve technique using easy to use pump, filters, and then the blood is bagged again for retransfusion. It went through a lot of processes. I'm not sure what I have in the picture there is the last of it, but that was what I could get from the literature. But somehow it fell out of grace at the utilization stage. It's no longer being used in any part of the country. Then a group of American engineers, I think they were final year students, visited a hospital in Ghana. And when they saw the scoop and sieve technique that was being done during ectopic pregnancies, they went ahead and designed the giant syringe as part of their final year project. I'm not sure this giant syringe is still in use. I could not see evidence of it in the literature. Now, like I said earlier, we should remember that there are other things that can cause death in a hemorrhaging patient. Electrolyte imbalances. So if we have acidosis, we need to correct it. We could also have coagulopathies, which can be as a result of hypothermia, apart from excessive use of fluids. So instead of giving so much fluids, we should also remember that in this group of patients, restrictive fluid management could be very useful instead of the liberal fluid therapeutic approach. Next slide. So cell salvage, whether using the cell saver or using the scoop and sieve technique, cell salvage has been shown to be very useful in emergencies. Next slide, please. So in summary, I want to say that cell salvage is beneficial in emergencies and can be done successfully with simple as well as complex equipment. Improved cell salvage service will, however, require investments in equipment and training of personnel. A clinical champion usually makes a big difference. Political will is so important because no matter how the clinical champion works and how willing the people on the ground are anesthetists, surgeons, and others who manage emergencies. If there's no political will, those equipment will not be bought. And documentation of clinical reviews is very critical. Even what we are doing, we need to document it so that the whole world can read and know how to improve and to keep improving. Let us keep patients' blood within the patients. I first heard this terminology from Steve Frank, that keeping the patient's blood within the patient. And I believe that we can, and I believe that we will. Thank you very much for listening.